about me, if I want to say, from childhood onwards, my actual biggest interest is to become as a artist. My father didn't accept to go into that, so I came into the dentistry side because I didn't like to join in the medical side. So I left my medical seat and took dentistry because that time my principal sir has told like, okay, there is so much of art in this. In dentistry, I really felt so much grateful to him because whatever I want for my fingers, everything is there in dentistry. So from childhood onwards, my mother also used to say like, okay, in our place, so much of this festival, Vinayak Chavati is so much fond of. So when want to buy any of the idols, she used to say, if you buy something, what you will get, if you make it, then really actually the pleasure will come. So like that the interest might have started. So the same thing has continued even in the further also, and when I came to my post graduation in ortho also, always that curiosity how these tiny creatures, these brackets are all made of, that is the main interest I used to have. After completing my post graduation, okay, we decide ourselves like with the marks, so okay, I got the university top, okay, so I know so much. I felt like I will go and learn about what I am having interest like that. So that time I took the list of all the people who used to sell the products and I started calling to all of them. And finally what I noticed is like all the people are just the dealers, not the makers. So then that time this person has informed to me and he told to my boss, and from the company that time in India only the place where designing and manufacturing facility is there is only JJ Orthodontics in Kerala. So after that I asked my father like, I want to go to there, I want to see there the work, and they contacted me. That time the first project of this self ligation is going on. So I reached here, my father didn't accept it as usually, and after the same bus from Hyderabad it comes till here Kochi also, Al Hind Travels at that time. I just got into the bus night and I came here. I don't know even a single word of Malayalam. That time I don't know how to pronounce it also. I said like move over to Puja like that, ZHA is there, na? So like that I came like that. So after coming here, what I really understood is like what we read in the books are all just marketing stuff. What actually happens, everything inside the factory, those things we are not known. So this is the picture which I drew in the year of 2010, which got selected as the best pencil art in India. So a small story about that is like, this is a live portrait of one model, her name is Preeti Bhatnagar from Chennai. When she first asked like, Dharma want a portrait, okay ma'am. So she said like, I will give for you 25,000. So that time, oh, 25,000 rupees to Mahan hai, like that I thought. So okay, I just went normal charcoal, normal thing, I drew the thing, and after that I left. After 3 months she called and she said like, Dharma, I will give for you another 50,000 rupees, I want all the rights of that and I want to send for the national this art exhibition thing is there, so I want, okay, what is there in that? Give ma'am, thank you, I thought. So after 6 months she called and she said like, it got selected in the best pencil art and it got sold at the price of 8 lakhs rupees. That time I really felt like actually the person who bought is really actually a stupid person. What? If you give 500 rupees also, I will draw in the same manner only, there won't be much of the difference. The same thing actually happens in the material in ortho side also. When the product is manufactured from the production side, those are all just products. But after that, how many hands of the dealers they changes? Only the packing will change, and it will come in the high price to us. And 3 years we do the work on the patient, and finally if someone asks like how the result came, we will give all the credits to that particular product, saying like because of that product. So, actually after coming here, I realized like what actually happens inside and what is actually we should know about. So, that time that is an art, and after that what are all you are seeing on the bag, these are my arts which became. So, how many has used the selfie bracket? So, how you feel, sir? Happy? So, a small claps for the drawing, how it feels, the same thing. Now, a product is working well, the same feeling. So, first when I started making this product, simple thing, this is not something big. On the paper, how many are here postgraduate students? Okay. Everyone, this is the from the day one onwards, we will make to read the students like what are the merits and demerits in the same each product. We always read those things and we write on the paper. If we assemble all the merits and if we make a one product, and if it is in our reasonable price, then obviously it will be so much useful for us. The same thought, first we designed that bracket of the selfie thing, and after that multiple modifications, so many things we have introduced, and today I am introducing to you about this new concept of selfylingual liner. So, why actually the requirement to develop this product came and what are the features of that. So, today I am going to give you the brief information about that. So, my objective of today's presentation is not to give any English vocabulary session, I am not expert in that. As an orthodontist, what I know in the orthodontic sense, I am trying to convey to you about these things. So, let us start into this one. This is the most beautiful video I like from the IOS Society.
Wants to hide, another one is out to shine. Shine like a diamond, shine like stars in the night. Everything just seems so right. Like a bird in a clear blue sky, like a fluttering butterfly. I'm gonna be free, just gonna be me, gonna be me, hey.
So, because of the better with mic or directly can you hear? Mic? Okay. So, because of the awareness in the digital technology and people seeing lot of the beautiful smiles every day in the HD quality. Nowadays, it is not like previous days we want to go and say to the patient like the importance of smile or anything. Directly the patients are coming to us and they are asking like, okay, doctor, is this type of technique is possible from your side? Is it possible for you like to do this type of approach? They are coming and directly they are asking to us. So, when the demand from the patient side, for the orthodontics is improving. At the same time, because of the digital media and so many companies promoting from the day one onwards when the person opens their social media, the term as invisible orthodontics, invisible orthodontics, invisible orthodontics. Lot of patients are coming and asking to the clinicians like the approach for invisible orthodontics. So when it comes to the invisible orthodontics, from long onwards, what are the possibilities we tell to the patients? What are the most common things we will tell? What we will refer to the patient, like if the patient asks for invisible? Clear aligners, okay. Next, anything? Anything we will tell? Okay, lingual. Then anything? Ceramic, okay. So from old days onwards, we follow like, okay, our chart will be like a menu chart in the hotel. It follows like, okay, metal braces this much cost, ceramic braces this much cost. Don't feel like I am giving some lecture or anything like that, just this is a discussion between you people and me. So when it comes to ceramic brackets, what actually you feel as a problems? What you feel actually as a problem? Okay, debonding, then bracket breakage, then stains, slow movement means friction. So in ceramic we are having monocrystalline, polycrystalline. Monocrystalline will be milled through the one rod of the material, and it will be having nice property, means strength wise or color stability wise, everything it is very nice. But the problem is always the strength should be equal to the opposite tooth. If it is more, if we are giving to a deep bite condition patient, total opposite teeth will get treated. And another thing is that brackets will be costing more in price. If we are saying from the production cost, I am not saying about more superior, even in the production cost also, base 6FR brackets or these brackets will be costing minimum to minimum of 4,000 to 5,000 rupees. But when we are saying to the patient like we are giving a ceramic bracket, the cost of the bracket will be maximum 1,000 rupees or less than that only. Those are all polycrystalline material. So polycrystalline material will be the same pattern how the metal brackets also manufactured, that is with the injection molding process only. So there what we will do is like the powder ceramic material we are going to make through the sintering process, and we will. So these furnaces don't make a proper fusion. So lot of time in the polycrystalline brackets we have this type of staining problem, breakage problem, brittleness, and at debonding time also all will get crushed. So these are all the most common problems we will see. And as I said, the main problem is even in the mechanics, friction. A metal bracket when we are doing even in the performance wise or even in the aesthetics wise, it at least gives as a metallic look. But the ceramic brackets, when we are keeping our elastomeric rings or everything, so the next appointment when the patient comes, because of our food habits, we like all nice masala things. So next time when the patient comes, it looks like very nicely yellow, dirty fellow like that it looks. So that is the problem with the ceramic. So next, when it comes to the option which mostly at present the people think is about aligners. What we can think the problems with the aligners are there? What we can think? Okay, first is removable appliance. So if it is a removable appliance, what is the problem? Patient compliance. So patient compliance is the problem. So we can't trust the patient. Next, cost. Okay, because here the number of the trays will decide the price for the patient. Next, Yes. This appliance inherently is suitable only for mild to moderate cases. When complexity is going to increase, the number of trays will be increased more, the duration will be increased more, and the price cost also will be increased. So, next coming to the last one, lingual. When we say about lingual, what you feel the problems with the lingual? There is a big list of problems with the lingual, right? Okay, we will come. Because when a patient comes to the clinician asking like I want lingual treatment, more than anyone, the first person who discourages the patient to go for the lingual is orthodontist only. Because if a 100 marks question for the lingual comes, our writing pattern will be like, okay, 20 marks we will write about the history of the lingual. It is just one company what they have made the pattern starting from generation 1 to generation 7, saying about that as a history, and after that we will go about biomechanics, another 30 marks we will write. After that 10 marks we will write about advantages, and after that our favorite is disadvantages, starting from tissue irritation, tongue problem, speech difficulties, food problem, all so many will come. So, that list of chart will be so much. So, that we will go in detail. So, now if I want to say in these 3 appliances, when it comes to the orthodontic appliances itself, means the potential of that appliance is for making the dental movement. We are having just a gross division, one is fixed orthodontic appliances and removable orthodontic appliances. So, in fixed appliances either labial, lingual, anything also, or removable appliances also. When we want to make a teeth movement, we want something to transfer the force, means as a medium to transfer the force, and another thing to generate the force. So, in fixed appliances like a bracket to wire mechanism, which will be the force generating component? Wires, elastics, all these things are the force generating component. Which is the force transfer component? Brackets. When it comes to the removable orthodontic appliances, as said like with the aligners, here also we want the same thing. One should be force generating component, another should be the force transferring component. Which is the force generating component in the aligners? Trays, plastic trays which we are using. And what will be the force transfer component? Attachments. So, first when you see this patient with the ceramic, do you feel like this is having a truly invisible look? Okay. As we said about the aligners also, first one they were introduced, just give plastic trays, it will make all the work. After that, no, just with the trays it is not possible. You want attachments, with that only you will be going to get a predictable result. What are these attachments? These are small pieces of composite cured resins which we are placing for the temporary purpose over to the teeth to transfer the force to the teeth. Okay. So, after that, no, these attachments are not sufficient, we need to increase the attachment size, or otherwise we want to give multiple attachments. And then how much to increase the size? Now, if you see in the conferences, equal to a ceramic bracket size, the attachments are getting increased the size. Okay. After that, no, that is also not sufficient, you want again auxiliary techniques, everything, elastics, all you need to incorporate, then only it is possible. And if we see with these attachments, is it going to give a truly invisible look from the patient to the patient? And when a plastic tray is placed on the patient, okay, if Pariniti Chopra comes and says Diwali ka din aa gaya, just take one laddu, go straight and take right, you will get a proper center and you will get the aligner. Okay, in an ad it looks very nice, right down to the nose. But actually when it comes a plastic look, it won't give that much as a natural smile look. even a normal layperson also can notice a plastic smile. And lot of time when the people go for the parties, before everyone, like Dada Dadi removing the CDs, if removing with the foul odor which was there and keeping outside, it looks so ugly actually. And with each aligner, you can produce only 0.3 mm of labiolingual movement, 0.3 mm of mesiodistal movement, 1 degree of tip, 1 degree of torque, 2 degrees of rotation correction, and 0.1 mm of intrusion and extrusion. This is the maximum calibration with each tray how much we can able to produce. So, if the complexity is more, then automatically the ability of the appliance is going to decrease and we want to give more number of aligners. That is the most problem. So, do you feel with this thing the patient is having a truly invisible look? Okay. So, now here you can feel like the patient is having truly invisible look, at least you can accept to that, but this is not our favorite. So, how many here are first year postgraduates? Second, final, and practitioners, all other sides. So, how many have started lingual orthodontics? So, as being as a postgraduate students, you people started lingual final year. So, final year is going to complete in how many months? 6 months. So, after that outside when you go, when any patient comes and asks like, sir, I have checked and I want to go for lingual, then what you will tell to the patient? That time we can't say like we do not know. Then what we will tell? Rather than saying that 3 years we learn one thing very best, that is like what we know, that we will make the patient to get accept. So, we will tell our list of favorites and we will make the patient like no, and we will make them to. So, today I am not going to say anything much. I am going to make you to feel like how many think here like lingual is difficult. How many thinks lingual is difficult? No one? Okay. So, everyone thinks. I am going to show like lingual is not difficult. And you people, everyone has done lingual from the day one onwards. When you started your first bonding onwards, for the anchorage purpose you are giving TPA, for the derotation purpose you are giving, for the couple force buttons you are placing, so many times distalization time, all the times you are using lingual approach. But when it comes as a complete appliance, you are thinking like lingual is difficult because we are not doing that particular appliance system, simple, that is it. So, I will just try to make you to feel lingual is not difficult, and after that rest is your wish. So, this is the comparison about the invisible appliances which we are having presently. So, as I said before, coming to the lingual appliance, for me, I became so much fond for lingual, mainly why? Because previously being as an artist, people directly easily recognizes me because my art actually makes the matter there. It is not what the pencil I use or it is not what the paper I use. It is the output what I am giving is the actual thing which is going to decide whether I am a proper artist or not. But when it comes to the orthodontist, I really felt so much bad after when I became a faculty, when I am trying to tell to my first year postgraduate student like to do the preclinical basic wire bending, And when some lectures, when the people come and says like there is no point of any wire work or anything required, just give the product and it will make automatically everything, then what I should tell to the student, if you learn this preclinical work and if you tame your fingers properly, there will be something use for you in future. That is the main thing which made me to push for making this modification development in the lingual appliances. Already the first product which made as a selfie is like a very big hit, which became, and not only nationally, internationally, everywhere also it got so much sold. After that, making the company to push in, invest so much amount in a product till now nowhere in the world which is available, and to invest in the miniature design which is so much complex, is only because if a student, if a person who is having hand skill, who want to genuinely to become as a true orthodontist, for them at least in the future should be there something appliance to show about themselves. So only one thing which can give that credentials is only lingual. Any another appliance, labial, whatever you do, how much complex mechanics you do also, at the end if you complete, people say, what is there in this that much difficult? It is easy. Aligners, if you have done anything also, at the end they say like that product has done everything. Everyone are afraid of only one thing, that is lingual. So why I like lingual, I am going to just tell to you. First thing is like, as I said, it is the truly invisible appliance, which you people all agree. So I was just going to show you these two patients who are identical twins who came to the department, who wanted to go for the invisible approach. As a place like in Kurnool, most commonly what the people think as an invisible thing is like ceramic brackets. So when the patients came for that thing, I have told all the possible approaches, and this first patient wanted to go with the ceramic only. So at present what we think in the braces wise in ceramic also, most superior one is the ceramic self ligation thing. And for this patient she said like, I will go with the lingual. Okay. So this is the first patient what the malocclusion is having, and this is the second patient, and this is her malocclusion. So for the first patient went with ceramic self ligating, and for this second patient went with the lingual. So now when it comes to the comparison, immediately after bonding, the day after bonding, any of the appliance, either you say labial ceramic or aligner, by giving the attachments, after doing the bonding, the patient will lose the visibility of like how actually their smile will be. Till the end they do not understand. And second thing is like, immediately after bonding, the patient will get the prominence in their profile. When it comes to the lingual, how it is, it will be in the same side, and every appointment patient will have a clear distinction in the movements, how the tooth is going to move. And if they want anything like as a change, it is a fraction of just one bend in the wire to make that correction. So after bonding, next coming to the mechanics wise, the most preferable choice of the slot dimension we take in the labial is O22 dimension, O22 into, in self ligation if we say it is O26 in the passive self ligation, so that a 4-point contact properly will come to give a proper expression. When it comes to the lingual, the most preferable choice is O18 into O26. Why it is? Because in the labial you are something away from the center of resistance, you want more rigidity. So that is why we are giving O22 slot dimension, and when it comes to the lingual you are already so much near. So the rigidity will become more. So, that is why you are going with the overnight slot dimension. So, now just if we think, in the labial we have placed O14 wire and lingual we have placed O14 wire. So, the same wire, when it comes to the lingual side, it will work as O18 in O22 slot dimension, and by the next appointment it will complete all the alignment work, and then you can proceed for going for the space closure mechanics. So, after coming the next time the space completely got closed, and then it is going to work as a retention appliance. So, after that it is being as a retention from the inside, and this is the whole sequence what has happened in the labial. Can you able to appreciate the smile how it got changed in the labial? Because the total brackets makes the patient to have not a proper visibility how the smile changes, and even the profile also we do not assess exactly how the patient will be at the end till we go for the debonding. But when it comes to the lingual, every stage we have a clear visibility how it got changed. And at the time of before going for the debonding, if we see, do you think like this both arches in the upper and lower are well aligned, everything well aligned? No, yes. How you will assess in the labial? Normally the way we assess is like a wire which is like a deflected wire, when it becomes as in a straight without any deflection, we will obviously assess like okay, it is well aligned everything. So, if we see like this is properly everything in a straight one, but after debonding we will see these things as a problem. That is why lot of times patients ask like after doing debonding some amount if it might have gone inside, some amount if it might have gone in, like out to inside, it will be nice. That something is there na, that is the most difficult thing, because already we debonded the appliance. But when it comes to the lingual and after doing the debonding, immediately after debonding for the patient it will not give that much like a very aesthetic smile look, because the inflammation will happen onto the labial surfaces of the teeth or even the gingiva, those will be inflamed. It may take minimum 2 days to get into a normal. But when it comes to the lingual side, we do not take the consideration about these things how it is there. We always take the consideration about how these outside the teeth are there and how they are matching with the smile. So, that is why so many cases when I show also, when you see the arches will be different sometimes, but the smile will be in the same nice one, because we follow always that curvature, we follow always that profile view. These things we will take more into the consideration, because our view automatically goes in that way. So, after debonding, this is the clear demarcation which we will see in the patient, and we can keep this appliance same like that as a retention for more days also in the inside. So, next when it comes, so why I showed that video is like have you felt any difficulty in the patient while she is talking? Or you felt so much the patient is feeling like as a irritation, that problems in her face? That's it, simple. So next, why I like to go for the lingual is like more than about from the aligners side. In India, you people all might be knowing as a practice, first aligner production has started from the company here itself only, in long back 2014, that time only it was started. And we have seen n number of problems actually what happens with the aligners. Aligner problems won't start in first 2 or 3 years, after that it will come. So making, okay, how much for the doctor the problem will be there, that much for the production side also, because after that refinements, that is the only thing which will be coming. And lot of people just thinks like, because the mindsets were created in such a manner like aligner means nothing job for the doctor, just take the impression, give to the lab, they will send and will give to the patient. So nowadays we say like stop DIY appliances and stop not to give for general people, like that. If we think clearly, who actually making the patient to know about that appliances? When a patient comes to you and when you say these words like, okay, there is an appliance, aligners, we send to the lab and they sends and you just wear it and it will make the work. There is no need of any orthodontic thing. So then automatically what the patient thinks is like, okay, then that product is the main thing which making the work. And patients believe and trust more Google Mata than anyone words. So then in the search engine they write like best aligner companies in India. So once they write in the search engine, automatically whatever related for that, the pop-ups will start coming in their social media. Then it will come like aligners available at your home service just at the rate of per month 999 rupees only. Then what they will think like, arey, the doctor said like no need of doctor in that, why I should go and give to him? Okay, if you are going as a consultant practice also, after completing of the post graduation, okay, if the fathers are like very well established, everything very nice, papa, beta आपका studying everything complete हो गया, आ जाओ, अच्छा दुकान खुलाएंगे आपको और शुरू आपका धंधा. If it is like that, okay, fine, but not like that, na. After completion, then they will start like, okay, take the bag, go on the street and ask for the consultation. So now what the way of the people starts consultation? Previously like, okay, sir, your person is doing for 60-40%, I will do for 50-50%. After that, sir, no problem. Just when I come, give me 10,000 rupees. How many cases you keep? I will do. After that, they were just as sitting there and will be doing. First it feels nice. After that, you will get from your brain like what you are doing, what is happening, nothing will understand. And then aligners. Now a new trend has started. The consultant calling people also started like when the fresher comes, I don't know here whether it started in the Delhi scenarios, in South Delhi, those regions, when the person first comes, are you X or Y company certified or not? That is the first thing they will be asking. And that certification is there what? Just to know about that particular product, nothing actually as a mechanic sense, just to make you to become unpaid marketing executives. You need to pay for them. Now it is 1.2 I think. And for that again you need to compulsory send 2 cases. So that is the actual thing what happened. And when it comes to the consultation, you will be doing 2-3 times just impression taking, sending and coming. After that, that clinician thinks, why I should give for him the share? I will only take the impression and I will only send. What is the point in that? So we are cutting our hands. Why previously everyone are so much jealous of orthodontist? When I am studying my undergraduation only, that time PG is not there in our college. My sir is the first orthodontist of total Rayalaseema region, Muralidhar Reddy sir. So when he used to go for the consultation, he used to ask to come with him. Because of him only so many things I have learnt. So when person, he is a exclusive break practitioner. So before the people, when the person is doing the wire work, everything, everyone used to feel like, okay, this is not our cup of cake. Why everyone are jealous of orthodontists? Because we will just take one small bag and we will take major share as a percentage for us. And if you ask a undergraduate students of 100 people, maximum 90% of the students says like they hate orthodontics. Why? Because why? Wire bending. So wire bending is our main weapon. And first year, 1 year you are doing the preclinical wire work only, and it should have something for your financial side also as a benefit, right? Before a clinician, when you do just the 2-3 bends which are not actually difficult, if you are placing in a patient mouth, then automatically they will think, oh, this is not our cup of cake, so let them do on themselves. I am based at Kurnool. I am doing practice over there, and I am working as a faculty heading the department there. And my consultations surrounding to Kurnool and semi-urban rural areas. Apart from that, I go to every month Mumbai, Bangalore, Delhi, Kolkata, Hyderabad, and even Cochin also I come. So these are all the regions I go for the consultation. Why the people are calling me from that places also? And my thing always, I kept one thing, if I am going to one city or place, I will go to only one clinic, I do not go multiple places, because I do not like carrying, one day will be there, that day running, taking and going, that is not my comfort. So one place only will be there, and if anyone want, they can send to that place and I will do like that. So over the time, what I felt is like, if I am doing something, there should be first is recognition, and second thing is like it need to give a proper financial benefit also for me, and third most important thing is satisfaction. These three things are very important. So when I am going further, the same case, if I am doing with so much of difficult mechanics using from the labial, it won't have much of like even the article publication, the people says like, okay, it is also the same thing. Next, when I am going like according to the region will decide the price. Anywhere also, my way of saying will be like, I do not say much of the appliances. I say like, same like KFC with how the people say, if the profile is everything nice, I say like, you want with extraction or without extraction. With extraction 25 to 30,000, without extraction 45,000, like that. So I do not say self ligation or anything, all this. And next is like, you want visible or invisible. Visible will be 45,000, invisible will be 50,000. Like in the KFC they say like large popcorn and medium popcorn, the difference between that will be very less, because automatically they will go for the large one only. So next is like, that is when I am going for the semi-urban regions around to the thing. When I am going to the metros like that, same thing, I will say like, okay, 40,000 and 75 to 80,000 and 85,000 to 1 lakh, like this I just keep the thing. So that is when the profile is nice. If it is not, obviously if it is required for the extraction, I will say like surgical way of treatment and extraction. Surgical line of treatment 4.5 to 5 lakhs it will take. Non-surgically the same thing, again I will tell like okay 45,000 or 50,000. Because if I give so much of knowledge saying as a menu vada pav or all these things, okay you are having metal, ceramic, self-ligation, all these things, the patient see and they will go to the next clinic and ask like how much you will charge for the self-ligating bracket, how much you will cost for the ceramic bracket, what is actually this requirement for the patient. And sometimes a very mild diastemas, these things will be there. That cases I will go even if the patient is ready for 35,000-40,000 also, because maximum in 2-3 appointments I can complete in the lingual. I always calculate in manner like I need to complete the case in 6 months, and every month first when they are coming they need to pay 20,000. I will tell to the clinician like for the appliance cost is 20,000 separate, remaining thing may do 60-40%. This is my way. So automatically when clinicians are seeing also every month 20 and 10, next 5,000 when it is coming, they also feel like money is getting more for them and they are trying to keep more cases for me. Automatically my skill is getting improved, and next time when I want to go for the consultation also, there should be something which pulls me like to go for the consultation. If the same thing if I am doing again and again, then what is the interest which will be having in me? So when I am doing this side, automatically that gives me the interest. So if you see this case, the patient actually they sent for like missing lateral incisors were there. So they wanted just to go for the closure of the space, and after that want to place the implant. In the virtual it looks very nice, and the worst thing what the companies made the people to do is like showing these virtuals to the patients, saying like just see this is how the teeth will make the movement. These are all just like as a prediction, never happens in the patient mouth like this. Always we need to see these things as like as a force generating component, not like a tooth moving component. After that, lot of times the people they created like just give the aligners, and aligners are just for the people who are coming from the abroad, just give, take the photograph and post in the Insta. So for the next case you will get a discount, and the tagline smile journey started. That smile journey when it ends no one knows, only giving the boxes only will be there in the videos. So rather than being as a treaters, we are just being as a product delivery boys, and all the boxes we will be keeping in the clinics and showing about like okay when the patient comes they feels like okay these boxes are the things which is making the movement. So when it came for the refinement, this is the situation. They never seen the patient, and even after this thing also they don't see. The fit is not proper, so again take another impression, send to the lab. So this is the situation. Now for this to make the correction with the aligner, it is very difficult. As I said, only 1 degree of tip and torque correction you can do with the aligner. That time what you will do? Okay, the same scenario when it comes to the lingual side. Here also first this is the space which was there, we wanted to create the space here for the 1, 1, 1, 2, so that we can go for the placement of the implant. So this is the virtual preparation, ideal teeth setup. After that the same values were transferred and transferred to the patient, then after making the alignment. So now this whole segment will work as an anchorage, then we are pulling this tooth towards this side by taking this whole segment as an anchor. So next it came completely, after that went for the placement of the tooth. That's it. So how much time it has actually taken, if we see, is like I started at April and completed at August. May, June, July, August, means maximum I can say 5 months. That is it. And if you see here also, if you see this virtual, first of all, this virtual is wrong. Patient is having already posterior mesially tipped teeth and giving like as a type B type of anchorage. And in the virtual it looks like okay, occlusion is fine. But when it comes to the patient, if we are not seeing anything, this is the condition. You will see just in the virtual it is moving like that, but in the patient how many days they wear also, this is impossible, because that appliance inherently won't have that ability. There are n number of cases, especially now when I go to either Bangalore or Mumbai. Every appointment at least 1 or 2 cases which are coming are spoiled up cases with aligners, and the patients are coming and asking like we want solution. They are ready to pay, but their main thing is like they want the completion. 3-4 years they will be using, changing the clinicians clinics, but the same aligners giving interproximal reduction. So presently I am saying this scenario, when you people come in future, think like you maximum expect like all spoiled up cases only. That time what you can able to do. So for that, if we are going with the normal, straightforward, if we go with our regular mechanics, this patient is having class 3 situation. Already he went for the lower first premolars extraction, okay, upper is proclaimed and well aligned everything. So just went with the camouflage line of treatment. One appointment alignment, after that started going for the space closure, after going for the retraction and completing, then upper arch started and complete. Because here the result is not coming because of any of the appliance, it is coming because you know how to apply the force, how to do. The wire won't be a straight thing. I will show you in the extraction mechanics when you are doing retraction how it will be, the compensations, everything. You are not depending on some X or Y lab person who is sitting in the lab who don't know anything about orthodontics, just they think like making a graphic designing is same like as making as a tooth movement. So next, if we leave about that, now the new trend which started is like, because previously they spoiled up everything about the aligners through the companies, now they want some another thing to create the market to earn the money. So the new trend is okay, stop in-house aligners, course just 60,000 rupees. And frankly telling, when we first started the production, that time we use object printer. So that printer cost was that time 2.5 CR, okay, and only the resin tank, one tank cost is of that time minimum 1.5 to 2 lakh it was there. Within 3 years after that, Foam Labs entered into the market. So Foam Labs entered with the printer costing of 6 lakhs, and after that, now if you see, the printers are available for even 40,000, 60,000 also. digital things always evolves, everything will change. And always you remember one thing, there is different way of practice, that is industrial production, second is institutional practice, and third is individual practice. I work in these three things. Okay. Industrially, I can ask to the company like to purchase how much CR also, because they are doing bulk production and they can do and they can get also, that is their way. Institutional, there also do not happen much of the problem, because that is for the learning purpose and we need to learn actually. So, for that also if the institution spends, no issue, but individual practice, we need to be so much careful when we are investing something, whether it is actually profitable for us or not, we need to think. Now, this is the price which I am keeping in the present day scenario. How much is the cost which will happen to make your in-house production? I am not saying any of the expensive thing, I am saying just at present very cheap least price ones, and if you think this is the price. So, 23 lakhs is just 23 lakhs what? Is it very just? For me it is not just. So, after saying like in-house production, the price for the course is just this much only, and after doing that what actually we are going to do? Knowing is fine, but after that what? And lot of people talks about making, okay, make the setup with the software, after that go for the printing, after that do the vacuum forming or otherwise direct 3D printing. But how many talks about actually these things, the safety data charts? Being as a industrial production, we know how many norms we need to follow. When we want to make the production, we need to get the approval from the CDSCO, everything. And resins are not a play tools, they are highly hazardous. And these are okay, actually a proper valued first production company which is for the bio things, which they have given is this company, and they have given in detail about what are the categories they will be falling. Everything falls under category 2 or category 3. And if you go about this favorite, at present so many people talks about that thing, and it do not give proper data chart also, they say like about the data thing as not available, not available. And everything, as I said, it falls under category 2 or 3. And future you might be not going to know, that time you will be running around to the IVF centers. So many hazardous things are there, and how you will discard these resins? They show like nicely in a AC room, AC chamber, they will show like okay, make the printing, make you vacuum form. Those fumes are highly poisonous. And where you will throw? In the sink. Poisonous to the aquatic thing. If to the drug administration, if in the future gets to know, totally the things will get seized. Because resins, as I said, it is not for the playing, you need to follow so many guidelines actually. So, we like and make the hit of the movies, if Karthi makes the movie, okay, nicely saying about no plastic, okay, very nice, very nice. But after that, when it comes, we are giving to the patient, we say like, oh, this is the most advanced product you can just place in the patient and it will work very nicely. Direct 3D printed things should never give more than 30 days in a patient mouth. It is highly, highly, highly carcinogenic. But we do not say, because okay, someone has said without knowing actually the properties of those things, and we are blindly following and going on, because we have spent 60,000 rupees just for that course. Okay, fine. And at the end, the plastic look, as I said, it is not that much aesthetic look. At the end, it is a plastic look only. So, this patient came from Assam to Bangalore. She was getting treated for more than 4 years and she got irritated wearing the aligners and aligners and aligners. Her main problem is only to make the derotation of that particular tooth. Everywhere when going, they are doing interproximal reduction, giving the aligner, interproximal reduction, giving the aligner. How it can make the correction? Then I said like, see, if you want me to do, I can't go with that particular appliance. If you trust me, I will make the correction, because her marriage is in just 6 months, because patients also thinks like ortho treatment is just like a bridal makeover. They will come just before to the marriage, they will come like keeping the mehendi and the facial thing. They will ask like, I am having this much of time, is it possible to do the ortho treatment? So I said like, if you want like that, I can go only with the another approach from the inside. So simple. See, any of the expansion appliances, they are all from the inside only. It is very easy to expand from inside. So just given the arch, this is like the wire which is like something extra we have kept, so which will generate the space. From the lingual, you do not want to give any of open coil springs, nothing. Just the wire, if you are following according to the tooth contour, give to the ideal what you require. Automatically it will push and it will generate. So by the next, it created the space, then we hold this one, all the segment as an anchor, we try to pull this one. When it came, we engage the wire into that. The benefit with the self ligation, previously rotation corrections are very difficult from the lingual, because you can't engage the wire completely into the slot. So that is why so many another techniques like Smith rotation ties, all these are there. Now especially with the self ligation, you can't close the door if you do not engage the wire completely into the slot. So we engage that completely into that. After that, it will not have any another choice rather than making the correction. After, just close the space and completed the thing like this. So we started at August and completed at December, September, October, November, December, 4 months. That's it. This patient also, when patient came, she already getting treatment with the aligner somewhere, and she asked for like closing the upper space. When seen inside, already she got upper 2 premolars got extracted. So to match for that Bolton discrepancy, went for the lower single incisor extraction, and then went for the first alignment and space closure and completed in this. And we can do it any age, because it is not appliance which is making. We are the people who are doing, we know how to control at what the time. According to the periodontal status, we know how to manage it. And lingual being near to the center of resistance, it is very much effective in giving a proper type of bodily movements. And even this patient also, lingual is one of the best deprogramming appliance, and especially in the cases like class 2 conditions, deep bite conditions, it is one of the best option. If you see this patient who is having like this, the patient, lot of time class 2 patients, what they say is like they have prominence in the maxilla, because they can't identify the mandibular deficiencies. So when you see like this, what you will actually suggest and prefer? Age of the patient still in the growing, just 12, like that only, not even pubertal crossed, still growth is there. Functional appliance, any of the functional appliance if you give, the concept is same, that is bring the mandible downward and forward, make the posterior teeth to erupt and make the condyle to get the growth potential to happen. So with the lingual, when the VTO is positive, see, if you see, she is having here end on thing, okay, and when we bond, immediately what happens, this anterior guidance will bring the mandible towards forward. So automatically here it is going to come into the class 1 relation, and automatically what happens by the next, that all the teeth will get adapted to that position by making the eruption. And upper, which is having like prominence with the lateral, these things, by going to the rectangular we can do with the retroclination. If you see this type of cases, it looks so much like a difficult, but when it see from the inside view, those are the best treatable cases which can make so much of change in the patient, because we are not just taking the anchor support from the back side and pulling them back. So you have the maximum chance lingual side with the anterior bite plane effect, it will work as simultaneous intrusion and retraction. So no need of additionally any TAD support required, you can do simultaneously the both things. And if you see, these patients are not highly payable, these people, very, because when we see that patients, it feels like okay, we can try the thing, and trust me, the most happiest feeling will come for the patients who we do for these patients, because if we say like 50,000 first appointment, 10,000 every appointment, 2,500, if we say also, genuinely they bring that much amount of the money and they will give with so much of satisfaction feeling. I treat in even Mumbai also, there two sectors of patients will be there. One sector of the patients very difficult to live in that much high cost, so they can pay only 500, fine at least. And second sector of the patients, high models, all these people, and those patients will pay it one shot, but that one shot when it will come we need to wait. And another thing is like nowadays new trend, sir I will do reels for you and I will promote nicely, can you give the discount for me? Are bhaiya, if you want to get treated, treat, or otherwise go. I don't want any reels or all these things. So like that the trend scenarios, because why they are asking, other people are encouraging like that, rather than being as a genuine practitioners, people are just becoming like okay, reel makers. So think. So another thing is like in 3 dimensions, either in transverse, anterior posterior, vertical, this is the most effective appliance in biomechanics. This patient actually wanted to go for the treatment without extraction, her profile is fine, but inside if you see the crowding is this much is there. So nowadays it is most common thing, you all might be knowing, because of the advent of the self ligation with the broader arch forms, when there is buccal corridor space available, when the potential for the expansion is available, it is very easy to do, and it will be 3 times more effective when we come from the inside. So when it comes from inside, in the upper arch we have started like this, and if you see this all the way, that generated the space everything for making it completion without going for any extraction in the transverse dimension. And in the vertical dimension also, when the deep bite fully is there, this much of crowding, we can make completion without going for any of extraction. And if you see this case, especially class 2 D2 cases, we can get simultaneous protraction and intrusion. If you see inside, this much deep bite, cross bite, and having class 2. So automatically this is making the push for out and bringing into the occlusion. Same here also, going for the camouflage line of treatment, upper force extraction in the class 2 and going for the retraction. So in all 3 dimensions it is more effective, because it is all the hand which makes the work. And lot of places, if we are thinking like okay, now the scope of ortho is decreasing, no, there is so much of scope is there, you need to give the possibilities. I am having so many of another disciplinary people who gives like a requirement lot of time, this will be the problem. If they want to go for the prosthesis here, because of the extruded teeth which is there, they can't able to place the prosthesis. Otherwise, what they need to do here, in intentional RC need to be done, and after that cut need to be done, then can place the placement. Otherwise, it is a very simple placement. We are not going full arch also, just as a segmental thing, taking the support. This 7 I want to go for the intrusion, just one tad we are placing the intrusion effective. So, automatically it will go, because you are very near to the center of resistance, bodily you can get the intrusion, and it will generate the space for going for the prosthesis. So, in all the dimensions it is the most effective appliance. So, just try to decide you want to be in one and all, or otherwise you want to make yourself unique. Because okay, I am also coming to the end of the generation, you people will be the next generation, what you people will tell future will also go for that thing. Now in the colleges, institutions, if we check what is the requirement, people joining for ortho as a post graduation, 3 years you are spending your valuable time. That 3 years, if you open your clinic outside just completing the UG, that clinic will become more established. The main thing is like at least to have an idea about all the appliances, without having any of the knowledge about the appliance, just reading as a theoretically, saying like this is good and that is bad. After that, if you can't able to do that thing, it is not only you people, there will be some one person will be there who can try to do the thing, and automatically he will have the opportunity. So, this is the advantages which I have said, apart from invisible at any age, flawless smile. Fixed appliance means it is going to have a predictable treatment result, and you are going to have a full 3-dimensional control, because it is having a rectangular slot, and most important is you will make yourself as unique. So, these are all the advantages which we discussed, but our favorite is like these are the things. So, these are the all the problems which you will feel saying like from the lingual side, right? So, now if we go for one by one, what might be the reasons for that, then you will understand what the solutions you can give for that. First is like okay, tissue irritation. When you first started on the day 1 of your bonding thing in your PG curriculum, patient felt very comfortable from the outside also. After that he didn't complain any of the problem. Huh? No? Huh? They complained. What they complained? Irritation is there. So, what is the reason? Huh? Okay, bracket if it is sharp, okay, that is from the manufacturer's side, need to be adjusted. Next, from your side. So, ligating, the wire which you are ligating, if the ends are not tucked properly, that is first. Second, distal edges, if you have not cut properly or bent properly. So, these are the most common things which give very highly irritation feel. So, the same thing even in lingual side also, if you are tying and tucking the thing not properly, and distal edges, lot of time the people what they use is normal distal end cutter. Okay. That distal end cutter, when you are using the safety distal end cutter, it will give minimum 1 mm of the distal extension will be there. With the flush cut it won't be there, with the normal one that will be there. That is the most irritating thing for the patient. Always you need to do the bend which is towards, not like it need to be towards to the tooth surface, like this it should be, not up or down, then there won't be any irritation. And next is like speech difficulties. When you place a lingual button for the patient for the derotation, anytime any patient said like very difficult in the speech, Did they said any time? Lingual button. Yes. Yes. Lingual button also said. Okay. Okay. If TPA, pendulum appliance, huh? Always profile makes the matter. If you are placing normally buttons, patient don't feel much of that much difficulty. If you are making a bulk big things, then the patient will obviously feels like very difficulty in the speech. Previously in the name to simplify lingual, lot of people what they try to introduce is straight wire in the lingual. So what is the concept of straight wire? See, in the lingual side we are having deviations in first order, that is in out. So from the lateral to the canine, canine to the premolar and premolar to the molar, there will be the deviation. So to simplify, what they thought is like, okay, we will give same as a labial thing, we will give a straight wire. So if we want to give a straight wire, what need to happen? This much compensation what will be there from the base, that all will be given in the base and that bracket will become more bulky. So when it becomes more bulky, automatically what happens? It will take more of the tongue space. So automatically patient will feel more difficulty in speech. And another thing is like, previously the people whichever they provide in the name of customized brackets, anything also, they are all crude directly DMLS printed brackets which are not a properly made brackets. So they don't have a proper finish. When finish is not there, you place a button and you place a big bracket onto the patient. With the button, patient says any problem. If you place a big bracket onto the lingual side, patient says like, okay, there is a irritation, because it will have a sharp edges. At the end, remember one thing, lingual appliance is skillman's appliance. This is the only appliance which decides the person is skillful or not. Simple, that's it. So next is gingival impingement. If the flush around the bracket is there, that is the most common thing which causes the plaque accumulation. And second is like elastomeric chains, rings, these things will accumulate more of the plaque and causes the gingival inflammation. Next, occlusal interference. This I will talk in separately. Previously, to make the rectangular wire to work as a rectangle to pass through the slot, we need to go this bracket more incisal. Why it is, I will explain it. So when it goes more incisally, automatically occlusal interference will happen and automatically debonding also will happen. Next, appliance control. What is meant by appliance control? When you will say like you are in proper control. When you think in your brain something, if you talk and what you talk, if you do, then you will say in control. You think something, you talk something, you do something, then you say like that person is out of control. Same appliance also. You expected something to happen with that appliance. If it works same like that, then you will think like this is under the control. Why we say like appliance control is not there previously? Because lot of time we are trying to place the wire into the slot, but we don't know whether you are completely engaging the wire into the slot or not. If you don't engage the wire completely into the slot, you expect like okay, it is working, but it won't work. Next is appliance placement and bonding. Because of the difficulty in the accessibility, we have the problem. And prescription. It is not universally one prescription which will be there because of the variation in the contours from the lingual side. And next is wire placement. Because of the inside to do the ligation, all these things which is difficult. And last but not the least, the important thing is expensive. Previously, just one STB bracket used to cost of 32,000 rupees. And insignia incognito used to cost of 1.2 lakh. And okay, local people when they are giving also starting from 40,000 to 60,000 they used to give. So how much you need to charge for the patient? How many cases you can do? I still remember when I was in my intermediate, when Swift entered into the market, two ads used to come. One is rocket ad and another is ship ad. So in a meeting, one person will be explaining very nicely about the rocket and ship also, and all the people will be sitting, and hamara Indian person asks like at the end, kitna deta hai? What is the mileage of that? Because actually that is very important thing in the Indian scenario. In India, the market is bulk market. Here the product price should not be more, because patients can't able to afford that much. If the product itself costs around 50 or 60,000 rupees, how much you can charge for the patient? So lot of time what the patients will think like, okay, everything the money is going into the pockets of the doctor. No, they don't understand like these are all the money which is going into the pockets of some other lab people. So always the product price should be as minimum as possible, so that automatically what will happen? You can get more expertise, you can do more. When you are doing more and more, you will learn more automatically. Simple, that's the thing. So if you see lot of things here, everything is related mainly with ligation side, because either irritation or otherwise prescription side or wire placement, everything is related with the ligation. In labial side, if you are doing a metallic ligation, the performance what you expect with the self ligation, the same thing will happen with the normal bracket also. There is no much of the difference, but actually the requirement of self ligation more than in the labial, it is there in the lingual side. So now to get a predictable result, that's why now we first introduced, because I am from Andhra Pradesh, okay, even though the state is divided, we are from first onwards so much near to Hyderabad, and we are so much fond of biryani. So biryani concept is this thing. You know what is the story of biryani? That time Nizam people, for going for the wars, taking so many type of dishes, it is very difficult. So take all the things and keep into one thing and make the thing biryani and feed for the soldiers. So aram se they can go for the war. So mix everything and make one thing. That is the concept of biryani concept. So when you write at present, if a question comes, recent advancements in orthodontics, what you can say like recent advancements? First, okay, self ligation. Next, aligners. Okay, aligner means it is like customized appliances, digitally done any of the thing. Next, what is the main thing which is making the work for making a borderline extraction into a non-extraction? That diamond only. What is actually in that diamond making the work? Highly flexible, thermally activated copper nitride wires, universal arch forms. These are the things which is making. So these are the main things which we can write as a advancements. Those are all the same things which we merged into the thing. First, okay, introduce the concept of self-lingual, but just by seeing the name of the lingual, people feel like, oh no, because wire bending is difficult and we are not fond of lingual, right? So that's why after that again we thought like, okay, to make the combination of lingual and even aligner also, so complexity corrections. With the aligner you can't do major complexity correction. So at the initial stages, major complexity, everything you can able to reduce through the lingual, and when you make it simple, lot of people feel difficulty at the finishing time corrections with the lingual thing. Okay, because you are not that much favorite of the wire work. So, for that, to make ease, we are adding again the aligners also into that and giving the finishing sets of the aligners for making the correction. So, combining all the advanced appliances what are all there, providing at the best available possibility. So, in the last IDS Germany, because of this product we got the opportunity, like in past 100 years from the India it got selected as the novel innovation from the Indian side. Because till now there is no complete passive self-ligating with 4-point contact design from the lingual side. So, that is one of the advantage which is very difficult to manufacture. Here we have a skilled labor which is available, but outside it is not, everything, the pins, everything need to be manually only placed. So, it is difficult to do from anywhere outside. So, now coming to the concept of self-ligation. First, I will just explain in that selfylingual aligner. So, how it will make the work? First is self-ligation, that is selfie. So, what is actually selfie means? When I first started the project to make the communication simple, I am not that much intelligent person. So, anything if I want to remember, I will make like a code, or otherwise I will make some story to remember, so that I can remember. Otherwise it is very difficult for me to remember. So, that is why the same thing at the end with the product also, what are the objectives I need to fulfill. So, the objectives are like, first is we need to give secured ligation. So, to give a secure ligation I opted to go for passive self ligation. Next is ergonomically the bracket should be designed for the comfort for the patient, at the same time for the clinician also. And third, light continuous force, for that we have generated this thermally activated copper nitride wires. And next, to reduce the friction, the concept of tip edge, chamfering of slot edges and supporting at the base 2 arms, so that a rail mechanism to pass easily without friction. And last but not the least, as I said, price. Because I can't use a product which is of 20,000 rupees in my scenario to the patient and saying to the patient, give me 40,000 and paying very less, because the same work I can do with less price one also. So, at the end of the time, if I calculate how many wires I am using, how much is the product cost and how much is my chair side time, everything if I calculate, it should be less than even normal bracket. So, like that, that is why first when said like, okay, what is the need of making the self ligation? Array, in the price of Maruti 800, if you are going to get a bench, you can take automatically, right? So, that is the simple thing. So, these are the objectives I wanted first to fulfill, and from first onwards, which, okay, after completing my PG, which I do not like is like 3 years I did my work, or after that practice I am doing. After that, if someone is asking like how the result came, either you say like Roth or MBT, or otherwise as sir said, Damon. They did not did any treatment, why to give the credentials for them? So, it is me or us who are doing the treatment. So, there is no need of giving the name, and frankly to say, even in the production side also I might be designing, but to get outside the product, it is so many laborers who are actually making the work. So, you can't take everything the credential firms. And if you go to the foreign products, they actually do not know inside the material side also. They just will be the faces for making the selling. If you go and ask about the Eastern masala to either Mohanlal or anything, they do not know, they just come and give an ad, that is it. Same like that other people also. So, these are the objectives I wanted to fulfill. So, when it comes to the lingual side, because of the difficulty in the ligation to make the wire completely to engage inside, we are using normally double over tie technique, and for making the derotation, Smith rotation ties, which are actually so much difficult, frankly to say. Just think, bracket is there, you are engaging the chain, you are pulling it out, and again you are placing over that. Your heart, it will, no need of, now already Covishield has said like, okay, after Covishield there is high prone for the cardiac attack, okay. So more extensive workouts, anything doing, high tension takes automatically, okay, chalo. So if we do just this thing, we will have like, when the bracket will come out, like that will be there, the tension. So automatically we will get directly the ticket. So that is the problem with the ligation thing. So that's why when we made the ligation, the door how it will close is like when you push towards to the tooth surface, it will close. So now problems with the conventional ligation is like full arch engagement, friction, oral hygiene, these are all the problems which are there. So to overcome that, the concept of self ligation, nothing but 3 walls were given by the slot, 4th wall you are giving, which is placed inheritant inside the bracket, which is either flexible or otherwise rigid. If it is flexible, then you will call it as like as a active bracket. If it is rigid, you will call it as a passive. Previously, so many people might have come from the lingual side in the name of self-ligating lingual, but they are all mock brackets which do not have any of the slot mechanism like forward and 2D lingual or 3D, they do not have like a proper slot mechanism. So only it will be used for minor corrections, not as a major thing. And in the active, if we are giving like as a Tommy Clippy L, these type of brackets, when active is there, the contours will be so much different and automatically it will be difficult from inside for the patient, and the control for opening and closure also will not be there. If you are pulling with force, automatically the door will come out, it will not have a proper locking mechanism. So now how it is working is like either in the labial or lingual we are following the same pattern, that is this door will be having one compressed and another relaxed chambers. So in the compressed and 2 nitinol pins. So when the door is open, these 2 nitinol pins will be under the compressed chamber in the compression mode. When it is closed, automatically they will come into the relaxed one. So that's why you will get that feeling like tuck feeling, the tactile feeling. That is not there in any of the another brackets, because even in the Demon other brackets also they use 1 pin mechanism. Here it is having 2 pin mechanism. So that's why it will be so much, once it is closed, till you open it, it won't open automatically, because they will be under the relaxed. So this is the mechanism of the door, how it is working. And next, what are the features actually incorporated in this bracket is, so everything is having correlation with the clinical scenarios. So I will just give brief summary of what actually these things are. First is compensation torque. What is meant by compensation torque? That I will explain in detail after. And compatible for customization. What is customization and how it will be done, that after we will see. And bite guiding tithing. What is this? As I said before, especially used for class 2 condition and even in deep bite conditions also. Just works as a bite turbo which is having a guiding thing also. And next is center scribbline for the second order verification and identification mark, opening door for the opening thing, smooth edges at the edges for not having the irritation, and hooks which are like half cut spherical and capsular, so that when you are placing any flush comes, it is very easy to remove, otherwise it will be difficult for that. And hooks which are engaged because for multiple treatment requirements. And base is like 2-piece type, means base is separate and head part is separate, which are merged. So the mesh when we are giving with the normal thing, that is 80 gauge mesh base, So, if you want to go for the CAD base separately, you can merge to the base separately, or compo base separately can place anything, it will make the work. And diving, which is deeper one, and slot about compensation. What is meant by compensation torque? So, here if we see what is the ideal inclination of upper central incisor to the occlusal plane? How much? Directly see here, it is 57 degrees, okay, normally ideal inclination. So, for that inclination, if we measure with a perpendicular line to the facial axis of clinical crown, how much is the ideal value? That is 7 degrees, 7, okay, 7 is the ideal value. So, at the end of the treatment, we want to achieve 7 degrees of torque for the upper central incisor. So, first I am explaining about third order compensation. So, to achieve this 7, first with the Andrews appliance, when it is given as a straight wire appliance in the pre-adjusted edgewise, when incorporated that same value, it might be not sufficient. So, that is why he has given so many multiple variants, like for class 1, class 2, class 3, extraction, non-extraction, multiple series. Class 3 bracket is the same bracket which was used for the Roth bracket, and which is having the value of plus 12 degrees, because when we are doing for a extraction case or when we are doing the retraction mechanics, we need some additional value. So, that is why rather than plus 7 we are keeping plus 12. After that, rather than frictionless mechanics, we are going with the frictional mechanics by using sliding. So, went with the MBT, which is having plus 17. Okay. So, this additional value whatever you are keeping, we are calling as compensation. Okay. If your wife or girlfriend ask like, I want a bag of Baggett or anything, that means like they want Monte Carlo. Okay. So, we need obviously something higher thing to give them, so that after that we do not get any of the tension. Otherwise what will happen? I asked this thing only, you got the same thing, till I did not ask, you do not got. So, all these questions will be there. So, you need to give some extra compensation, then you will be in peace, right. So, same like that. So, that is the extra compensation. When it comes for the lingual side, the same bracket which is on the labial, if we are just transferred to the lingual side, okay, to make this bracket as rectangular slot, there is a requirement of this much compensation. If you are not giving that, if you are placing directly onto the tooth surface, then what it will become? Rather than a rectangular slot, it is going to become as a vertical slot. Okay. So, to become at least to a rectangular, as I said previously, they used to go more incisively with all these customization techniques, either you use class, torque, Hyro, any of the things. You are trying to bring more incisively, so that there is very minimal requirement of compensation, which will be means compensated with the composite. So, what happens? That is going to give the occlusal interference, and it will make the debonding issue. So, now because the slot dimension in the labial selfie is, we are using 022 into 026. So, when you are placing the higher dimension wire, that is 022 into 025 wire also, it is having a full expression. So, that is why we have given the value of plus 12 degrees only, not anything more, okay, because it will express more. So, now that same value of plus 12 degrees, when I want to transfer to the lingual side, The same thing if I want to get here, I want to give how much, that is of 60 degrees I need to give. So, now the same one, when it comes to here, I want to give the compensation of this much, that is 60 degrees. So, that additional everything will be incorporated in this base. So, 3 years you are learning one technique, that technique only you are doing even for the selfie also, that is MBT thing. So, bracket positioning, that everything, the values 4.5, 4, 4.5, the same sequence you are going, the same value, how much it is required as a compensation, with that only this was also made. So, this is what it will make that bracket to work as a rectangular slot as 60 degrees compensation in the upper anterior. The same thing when it comes to the lower anteriors, we require 45 degrees, so that it will work as a rectangular slot. And for the premolars posterior, it is of 11 degrees, minus 11 degrees. And molars, it is as equal, it is on the labial thing. So that when you pass these all things in a rectangular, they will be falling in the same line. So, this is the concept of third order compensation, so that it will work for all the techniques, either you are doing with the indirect or otherwise direct, you are going to make that bracket work as like as a rectangular slot bracket. Okay. So that how it will be sitting? It will be sitting like this on the cingulum surface. The most predictable area for the lingual is over the cingulum, so that it can sit in a secured manner. So, next is that compensation which is there will be used mainly in the extraction mechanics to do the retraction. So, that time, even though you are giving the compensation in the wire, everything also will be transferred. Next, coming to the second order, the scrib line will be guiding you for the long axis, and how much is in the labial 5 degrees, the same thing will be transferred when you are passing to the lingual side. And next is the main important variation which is there, that is in the first order. So, in the labial, if you see, there is very minimal deviation for the central to the lateral and lateral to the canine, and premolars there is maximum 1 mm, 0.1 mm is the difference which will be there. But when it comes to the lingual, there is so much of variation from the lateral to the canine, canine to the premolar, premolar to the molar. There is so much of variation in out which is there. So, to make that adjustment, we are doing this customization. Customization is nothing but making an ideal setup, and that ideal setup values you are going to transfer to the bracket or otherwise wire, and after that you expect at the end mushroom shape also. If you are engaging the brackets, you are having a difference of value of this much. So, that will be given as a composite base when you are transferring to the teeth. So, next is otherwise only head parts you will engage to the wire, and after that this base part everything we will design, and that will go for the DMLS printing, and then it will be laser sintered, laser welded to the bracket head and will be transferred. But the problem with the CAD base is like the strength which will be getting with the normal 80 gauge mesh base, you can't able to get, because that is why if you see previously all the CAD bases, they will have more surface area, you will get all the strength because of the micro etching which was done with the blasting. it will not have any honeycomb or any of like a mesh basis. So, we will have very minimal bond strength with the CAD basis. So, that is why we opted to go with the basic, that one only, and how we will give that composite transfer, that values is like we will go for the direct 3D printing of the transfer tray. Into that the brackets will be engaged, and that composite when you are placing and placing to the patient, automatically that values will be transferred to the patient. And next is wire customization. So, to decrease the in-out thing, wire will be first customized according to the form, and to that one the brackets will be engaged. So, very minimal the requirement of the compensations will be there. And final thing is like if you are going with the direct placement of the brackets, as I said, the same thing with the simplified lingual thing you can place on the patient also, and after that the wire you need to modify every time sequentially to get into the proper thing. So, this wires everything as labially how you are using, you are going to get as a sequence of the wires everything which are thermal wires. First time in the thing, thermal activated copper nitride preform wires which are customized, everything we are producing with the robotic bendings. So, it will come as a sequence of O12, O14, O16 round wires. So, if you are ending till this, that is 2D lingual. If any third order requirement is there, that time you can go for the rectangular. So, then it will be called as 3D lingual. Lot of cases you can just end up with the round itself, because if there is no third order requirement. So, now this is the way how the wires are fabricated. Now, with the advantage of passive self ligation and thermal activated wires, if you see this type of condition, the arch is like this, which is highly constricted. So, what you think you will try to go for this approach when this much of crowding is there and this is the situation, what you think like you can go for this if you are doing with a regular. Most of the time we say like we will go for the expansion appliances, any expansion devices we will. So, if you see here, this is the advantage with passive self ligation and highly flexible thermal copper nitride wires. It works simple just as like as a nitride expander. So, when we placed into the patient, this is the starting. You have not given any bends in the thing. First, whatever it is available, that teeth only you will go for the bonding. After that, when the space got achieved, then you are bonding another teeth and going for the engagement. Then we are using this segment as an anchor to do the derotation. Then after completing engagement and completing the thing. So, coming to the workflow of what I said, this lingual or lingual liner, how it works is like when a case comes, first we are going to convert it into the STL format. After converting it into the STL format, we are going to make into a ideal setup. After making to the ideal setup, then we are going to make digital Hyro setup. First the wire will make, and to that the brackets will be engaged, and after making the brackets engagement, then we will make the STL of that 3D printing tray, and after that it will go for the fabrication of the tray, and that is of triple layered tray. So, outer tray will be the rigid one, which will be engaging bracket at the exact position, and inner is the flexible one. So, it is very easy to peel off, and next is protective one under to the hook. So, the flush will not come, down to the bracket. So when it comes to the bonding, if you see this molar which is rotated, so for making to this derotation, when we are engaging the wire which is already a customized wire, automatically it will make the deflection in the wire, so that by the next time it will come into the derotation, and after we are going for the finishing thing where it come completely into the class 1, and finally finishing anything. In the deep bite cases, I go for the anterior from canine to canine only, the retainer, so that automatically the posteriors will be under the eruption. So this is the whole workflow of lingual appliance, how it is going to make the work. From here, which is retrognatic, which came to the front, same thing, and pre.
To do bonding for that particular treatment?
Blocked out.
You had blocked out incisors which you didn't bond initially.
Yes, yes.
How did you get to bond that in that?
Placement of the bracket to that.
Only
That particular segment.
So when you are fabricating indirect trace,
Yes.
you are sectioning it into three and then giving it initially.
No, 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 no. Will be coming completely as a one single one, it will be coming. Okay. So that particular segment which if want, okay, what happens, this is all first will be placed onto the final setup. Okay. I will tell. See, now after making, first we will make the ideal final setup. After making this final setup, that same value will be transferred to this initial setup. So first when it gets to the ideal correction thing, okay, if the space gets open, after that you can make this one as a reference. We will make this one for the print, and this one will be making as a individual section, and that particular bracket will be provided, and that will be used for the placement.
So you ship it.
Yes, yes, that will be separately placed.
For the first aligned ones, you'll be giving it sectional separate, and
Yeah,
for that.
sometimes if it is like completely as a arch form will come, but in the patient when we are placing, it is not accessible for placing. So that time what we need to do is, like that tooth we don't want to transfer, we need to bypass that one, and when the space gets open, after that, that particular tooth can section and can be placed. Sometimes completely it is not accessible and it is not possible for placement. That time we will be separately sending that one tooth as a separate transfer, like that. So after that, this is the whole workflow of the lingual thing, how it is going to happen. So at the end, the key for all the success is like just come from your comfort zone and take a step ahead and get over your box like, and make yourself to become confident and remove the fear from yourself. Long before independence, this person has thought like, okay, how the country should be, saying like, where the mind is without fear and the head is held high, where the knowledge is free, where the world has not been broken up into the fragments by narrow domestic walls, where the words come out from the depth of truth, where the tireless striving stretches its arms towards perfection, where the clear stream of reason has not lost its way into the dreary desert sand of dead habits. Into that heaven of freedom, my father, let my country awake. But if you read that poem, line to line, how he wanted the country should be, we people be exactly opposite. When we open our mouth, never comes the truth. What we know, that only we will make the patient to do that appliance. And we divide ourselves, like saying, I am an exclusive this practitioner. When recently goes for the national symposium workshops, people says like, I can't do this type of difficult thing, ortho, I hate that thing. If you hate wire work in ortho, then what is the thing you like? Ortho means that only actually you should love, and they teach to the people showing like that is something which is not to love that thing. So if you hate driving and if you want to become like a big driver means it is the funniest. So at the end of the thing, if you have a proper biomechanical sense and what you want to do, it is very easy, you can achieve that thing. So till now I have just showed you the possibilities. If you want to know how all these treatment techniques, everything happens, there is so much part of biomechanics is there that you can meet up in the next any another sessions. We can discuss about that, because nothing will happen as a magic. Everything will have a logic, that is biomechanics sense. Okay. So till this today I am going to end the session. As Varghese sir said, to keep concisely, then we will go for the just some brief explanation of how to do the transfer tray transfer and how the bracket. Yes. Sir. Yes, sir. Lingual, see, settling, see, lot of time actually I never required the elastic, sir, because automatically the anterior, when it is giving the relief guidance, the posteriors will be coming into that proper occlusion. So actually I never felt much of like a settling requirement correction, because I am following the arch form same from the first onwards. So they will come into a proper intercuspation if it is required. That's why we have kept hooks also engaged if it requires. Any more questions?